Welcome to the Depth Dive. Today, we're tackling a really critical and honestly pretty complex area in medicine: infections of the bones and joints.
That's right. Things like osteomyelitis, septic arthritis conditions that can have a massive impact on people's lives.
And for this deep dive, we're using a really solid source, right? A detailed text from a surgical practice guide.
Exactly. It's designed to give you a thorough, comprehensive grasp of the subject, the kind of understanding you'd need if you were, managing these cases yourself.
Good, because these infections, they're not just historical footnotes, even though, as we'll see, they're ancient.
Oh, incredibly ancient.
They are more relevant and, frankly, more challenging today than ever before. They really hit patients hard, physically and mentally.
Absolutely. The physical damage, the disability is one thing, but the toll on mental health, quality of life, it's significant.
So our goal today is to really unpack this material for you. We'll dig into the characteristic features, how we diagnose these infections, the principles behind that, and the different management strategies for various types.
The aim is to help you walk away with a really detailed understanding. Think of it as fast-tracking your knowledge on a complex topic.
Your concentrated download, basically. So you get that solid grasp without having to wade through dense text yourself.
Ready to jump in?
Let's do it. Let's start with that overview. Bone and joint infections. An ancient problem, but definitely a growing one.
Okay, foundational term first.
Mm.
Osteomyelitis. What's the story behind that name?
It's classic medical Greek. Osteon means bone.
Right.
Myelos is the marrow inside the bone.
Okay,
And itis, as you probably know, just means inflammation.
so inflammation of bone and marrow. Simple enough. What causes it?
Overwhelmingly, it's bacteria getting into the bone and setting up shop. Bacterial invasion is the core issue.
You mentioned it's ancient. How ancient are we talking?
Fascinatingly so. I mean, researchers have actually found evidence of osteomyelitis in dinosaur bones.
No way. Dinosaurs had bone infections. They did. And we see it in early hominids, skeletons from ancient Egypt, Rome,
Yeah.
pretty much throughout history. It tells you that bone infection is a fundamental biological risk.
Wow. Okay, so fast forward to today. If someone has a bone infection, how does it show up? What does the patient actually experience?
Well, it can present in really different ways. Sometimes it's incredibly dramatic, other times much more subtle.
Okay, give me the dramatic end first.
That's acute osteomyelitis. The patient is often really sick, systemically high fever, feeling generally unwell. Locally, around the bone, you get major inflammation. Redness, heat, swelling, intense pain, and often visible pus. It comes on fast.
Sounds like something you can't miss. An emergency.
Definitely an emergency. But then there's the other side of the coin.
The subtle presentation.
Right, the insidious onset. This is more typical of chronic osteomyelitis. The infection might have been there for a long time, kind of smoldering away.
Smelled.
Yeah, causing gradual bone destruction over months, maybe even years. Function slowly gets worse. The pain might be there, but maybe it's less intense or comes and goes. Swelling might be less obvious. And crucially, these patients often don't have that systemic upset. No fever. They might not feel acutely ill at all.
Ah, so that makes diagnosis much trickier in the chronic cases.
Much trickier. It's not screaming for attention in the same way.
And the impact on the patient, does it differ between acute and chronic?
Hugely. Acute infections can be immediately life-threatening or limb-threatening. You need urgent action. Chronic infections, though, they can drag on for years, sometimes flaring up, sometimes quietening down, but they cause prolonged disability, constant or recurring pain, just a general state of poor health that really wears people down.
And you mentioned the mental health aspect, too.
Yes, the source material really highlights this. Living with chronic pain, limited mobility, facing potentially multiple surgeries, maybe dealing with wounds that drain. It takes a massive toll. Depression, anxiety, social isolation, it's all part of the burden for many patients.
Okay, so ancient presents differently, high human cost. And you said it's a growing challenge. Let's talk epidemiology. What's changing?
It's interesting, the pattern is shifting, and yet the overall incidence seems to be increasing.
Any numbers on that?
Globally, the estimate is about 1 case of bone or joint infection per 10,000 children each year, which is, a lot of kids affected.
Definitely. And why does it become chronic sometimes?
A big factor is inadequate initial treatment. If that acute infection isn't diagnosed quickly or treated aggressively enough right at the start, the source suggests up to a third of cases can unfortunately become chronic.
So getting it right the first time is critical to avoid that long-term problem.
Absolutely critical. Now, in developed countries, there's a noticeable shift in how these infections start.
Okay.
While bacteria traveling through the blood hematogenous spread still happens, especially in kids, we're seeing more severe infections starting locally, usually after an injury or maybe surgery. We call that contiguous focus osteomyelitis.
Starting right near the bone itself.
Exactly. And a huge driver for this type is the increasing use of orthopedic implants.
Things like joint replacements, plates, screws.
Precisely, the hardware we put in during surgery. And this rise is linked to a few things. People are living longer, often with more chronic health issues, diabetes, poor circulation, conditions needing immune-suppressing drugs. All these made people more susceptible.
Makes sense.
Plus, we're just doing way more orthopedic surgery involving implants than ever before.
Which naturally increases the number of opportunities for infection around that hardware.
It does. And one area where this is particularly stark is prosthetic joint infection, PJI. Joint replacements, hips, knees, they're incredibly successful surgeries overall. But infection complicates at least 1% of them per joint per year.
1% sounds small, but considering the millions of joint replacements done.
It becomes a massive number. The source cites a U.S. estimate for 2020, over 70,000 new cases of PJI just in that year.
70,000. Wow.
And these are notoriously difficult and incredibly expensive infections to treat. That 2020 estimate put the cost in the U.S. at over $1.5 billion.
Billion with a B. Huge economic burden on top of the patient's suffering. What about infections after fractures are fixed?
Well, the rate of infection happening immediately after the fracture itself has actually gone down a bit, probably due to better trauma care, which is good.
Okay.
However, because we now use internal fixation plates, screws, nails inside the bone so much more often to fix fractures, the overall number of bone infections happening after trauma has actually increased. More metalwork means more places for bugs to potentially cause trouble in a fracture setting.
So improved specific techniques, but the overall approach creates new infection risks. The guide summarizes the epidemiology, right? What are the key takeaways?
Yeah, the main points are: hematogenous spread is still common worldwide. Implants, both in joint replacements and fracture fixation, are a major and growing source of new infections, especially in developed nations. And patients with compromised immune systems due to illness or treatments are another increasingly significant group affected by these infections.
Got it. That sets the scene. Let's dig into the general principles now, starting with the pathology. What's actually happening down at the tissue level when bone gets infected?
Okay, so fundamentally, osteomyelitis is about inflammation. You get pathogenic organisms, bacteria, usually invading the bone and the surrounding soft tissues, and the body reacts with a really strong inflammatory response.
How does that inflammation damage the bone itself?
In the acute phase, it can quickly lead to an abscess, a collection of pus forming inside the spongy part of the bone, the medullary cavity.
Right.
As that pus builds up, the pressure forces it to tunnel outwards through the dense outer layer, the cortex.
Okay.
When it reaches the outside surface of the bone, it lifts off the periosteum. That's the tough membrane covering the bone.
And lifting that off is bad news for the bone's blood supply.
Very bad news. The periosteum carries a lot of the blood vessels feeding the cortex. Lift it off, and that section of bone loses its blood supply. It becomes devascularized, and that leads to bone death, necrosis.
The bone literally dies because it's starved of blood.
Exactly. And having this dead, necrotic cortical bone is really the defining feature of chronic osteomyelitis. You get these islands of dead bone within the infected area.
And what are the bacteria doing in that environment?
Well, that dead bone, or any foreign material like an implant, provides a perfect surface for bacteria to latch onto. And once they stick, they start building something called a biofilm.
Biofilms, we hear a lot about those. What exactly are they?
Think of it as the bacteria creating a protected community. They embed themselves in this slimy, sticky matrix that they produce themselves, mostly made of polysaccharides. It acts like a shield.
Okay.
Inside that biofilm, the bacteria actually change. They slow down their metabolism. They behave differently than when they're free-floating. And this state makes them much, much more resistant.
Resistant to what?
Both to the body's own immune cells trying to clear the infection and to the antibiotics we give them. It's like they've built a fortress that's really hard to penetrate and kill them within.
Ah, that explains why these chronic infections are so persistent and difficult to eradicate.
It's a major reason. Now, switching to septic arthritis infection inside a joint, the bacteria and the inflammation release toxins and enzymes that break down tissue really aggressively.
Specifically the cartilage.
Yes, the smooth articular cartilage that covers the bone ends. It gets damaged very quickly. That's why getting the infected fluid out of a septic joint fast is so critical to try and save that cartilage.
How does the living bone react to all this, especially in chronic cases with the dead bone?
The body tries to deal with it. It attempts to wall off the infection and sometimes even push out the dead fragments. These pieces of dead, isolated bone are called sequestra.
Sequestra, okay.
And sometimes the body forms tunnels, called sinuses, from the infected bone out to the skin surface. A draining sinus is a classic sign you might see with chronic osteomyelitis. It's the body trying to expel pus and maybe even tiny bits of sequestra.
And does new bone form as well?
Yes. The periosteum, even though it might be lifted in areas, gets irritated by the inflammation and responds by laying down new bone around the site of infection. This shell of new reactive bone is called an involucrum.
Involucrum. So you end up with dead bone inside a shell of new bone.
Often, yes. The classic picture of chronic osteomyelitis is sequester, dead bone, contained within an involucrum, new reactive bone, maybe with the sinus tract leading out. The diagrams often show this really clearly.
So the body's attempt to contain it actually ends up trapping the problem.
In a way, yes. Now, thinking specifically about septic arthritis again, how does the infection get into the joint in the first place? A couple of ways. It can be direct inoculation. Bacteria gets straight in, maybe from an injury that pierces the joint, or during surgery or an injection.
Makes sense.
It can spread from nearby, and adjacent osteomyelitis in the bone breaks through into the joint space.
Okay.
Or, very importantly, it can be hematogenous bacteria traveling in the bloodstream from somewhere else in the body, land in the joint, and start an infection. This route is particularly common in babies and the elderly.
Right. So key pathology points: bacterial invasion, inflammation, bone death, sequestrum, biofilm formation making bugs resistant, the body trying to wall it off, involucrum, and rapid cartilage damage in joints. Does the summary box nail these?
It does. It reinforces those core ideas. Bacteria forming biofilms, infected bone dying off, sequestrum, and new reactive bone forming around it, involucrum. Understanding these processes is fundamental.
Absolutely. Okay, pathology covered. Now let's talk microbiology. Who are the usual suspects causing these infections?
If we're talking about infections in native tissue, bone, and joints without any implants involved, the most common players are usually virulent, gram-positive bacteria.
And top of the list.
Staphylococcus aureus. By far the most common cause overall. It's a common bug, can live on the skin, but it can be really nasty when it gets into bone or joints.
But you said implants change the picture.
Dramatically. Once you have prosthetic material in there, a joint replacement, plate, screws, the range of potential culprits expands quite a bit.
Yeah.
You start seeing infections caused by organisms that are usually pretty harmless residents on our skin. Low virulence commensals, we call them.
Like what?
Things like coagulus-negative staphylococci, different from S. aureus, certain types of alpha-hemolytic streptococci, and a bug called Cutibacterium acnes, which used to be called Propionibacterium acnes.
Why do these normally harmless bugs cause problems around implants?
Because the implant gives them something to stick to and form those biofilms we talked about. Even though they aren't inherently aggressive, once they establish a biofilm on that foreign surface, they can cause persistent, really difficult to treat infections.
So the presence of the implant itself is a major risk factor that changes the microbiology.
Exactly. The source material has a really useful table that breaks down common organisms by clinical context.
Okay, let's hit some highlights from that table. Gram-positives first.
Right. Staph aureus is #1 overall. Coagulus-negative staph, specifically linked to implants. Various strep species, some, like alpha-hemolytic strep, often seen with implants. Others, like beta-hemolytic strep, strep pyogenes, causing more acute infections. Cutibacterium acnes is increasingly recognized, especially in shoulder infections, both native and around implants, and enterococci often pop up in diabetic foot infections and chronic osteo.
What about the gram-negatives?
A diverse group there, too. You've got the Enterobacteriaceae family, like E. coli, which is common at the extremes of age, Klebsiella and Salmonella, which has that known link with sickle cell disease.
Right.
Then there's Pseudomonas. You see that a lot in diabetic foot infections, chronic wounds, hospital-acquired infections, especially if someone's had antibiotics before. Kingella kingae is a big one for septic arthritis in toddlers under 4 years old. Haemophilus influenza used to be common in kids before the vaccine, still see it occasionally. And the table also lists Neisseria species, like meningitis and gonorrhea, reminding us to think about disseminated infections from STIs sometimes.
Quite a range. The table mentions others too.
Yeah, important not to forget non-bacterial causes. Fungi, especially Candida species, can cause bone infections, particularly in immunocompromised patients, those on long-term antibiotics or sometimes related to certain wound therapies.
And tuberculosis.
Absolutely. Mycobacterium tuberculosis can infect bone and joints, often without active lung disease. It's more common in certain parts of the world and strongly associated with HIV. Then there are atypical Mycobacteria environmental bugs, like M. marinum or M. ulcerans, that can cause problems, especially in immunocompromised people, or sometimes post-surgically, even in healthy individuals.
And sometimes it's a mix of different bugs.
Definitely. Mixed infections are more common after significant trauma, multiple surgeries, with poor wound healing, or when the infection spreads directly from a contaminated area like a chronic ulcer.
What about when the cultures come back negative? You can't find an organism.
That's the challenge of culture-negative infection. It happens quite often, especially if antibiotics were given before taking samples. In those cases, you have to rely heavily on the clinical picture, the imaging findings, and what the pathologist sees under the microscope, the histology, to make the diagnosis.
Underscores that point about getting samples before antibiotics whenever possible.
Critically important.
Okay, so that leads us right into diagnosis. How do clinicians put all these pieces together?
The main message from the source is that diagnosis is primarily clinical. It starts with suspicion based on the patient's story and the physical exam. Then you use other tests to confirm it.
What about blood tests? Biomarkers.
They're usually the first step. Inflammatory markers like ESR, sed rate, CRP, C-reactive protein, and the white blood cell count, WCC, are often elevated, especially in acute infections. But, and this is crucial, they aren't specific enough on their own. They can be normal, especially in chronic cases, and they can be high for lots of other reasons. So they support the diagnosis, but they don't make it definitively.
Are there any newer, more specific markers?
Yes, particularly for prosthetic joint infections, PJI. Testing the joint fluid itself for markers like alpha-defensin or calprotectin has shown pretty high accuracy and can be really helpful in diagnosing PJI.
What about imaging? X-rays are usually the go-to first.
Plain X-rays can be useful, but mainly over time. They might eventually show dead bone, new bone formation, periosteal reaction in involucrum, or signs of an implant loosening. The really critical point, though, is that in the first few days of an acute infection, plain X-rays are often completely normal.
So a normal early X-ray doesn't rule it out.
Absolutely not. You can't rely on a normal X-ray early on. Changes only become visible after several days or weeks in acute cases, or you see progressive changes like loosening in chronic infection.
Good point. What other imaging helps? Ultrasound.
Ultrasound is great for looking at soft tissues. It can easily identify fluid collections or pus, either in the tissues around the bone or inside a joint. And is often used to guide procedures like aspiration or biopsy, helping make sure the needle gets right into the collection you want to sample.
CT scans.
CT gives fantastic detail of the bone itself. It's helpful for checking fracture healing if infection is suspected. It's excellent at showing small sequestra, those dead bone bits, and subtle erosions of the cortex. It's also really valuable for planning surgery, especially if you need removed dead bone. The guide has images showing how clearly CT can map out this bony anatomy.
What about nuclear medicine scans? Bone scans? PET scans?
Traditional isotope bone scans get a pretty lukewarm review in the source material. They have very limited value because they're just not specific. They light up anywhere. There's increased bone turnover infection, sure, but also healing fractures, arthritis, tumors. They don't reliably diagnose infection or guide treatment.
Okay, so not very helpful here. What about PTCT?
18F-FTG PTCT, which looks at glucose metabolism combined with CT anatomy, can be a bit more useful. It can help pinpoint areas of active inflammation or infection, especially in chronic osteomyelitis, which can aid surgical planning. But it's still not specific just to infection. It can light up around implants due to normal healing, inflammation, or even loosening without infection, aseptic loosening. So you can't reliably use it to say for sure if an implant is infected.
So pulling all the imaging together, is there a preferred test?
Generally, yes. The source identifies MRI magnetic resonance imaging as the investigation of choice for most suspected bone and joint infections, as long as there isn't significant metal implant artifact that would ruin the images.
Why MRI?
It has high sensitivity and specificity. It gives a really detailed view of everything, the extent of infection within the bone marrow, how much the surrounding soft tissues are involved, any fluid collections or abscesses. One small caution is that sometimes the reactive swelling around the infection can make the area look bigger on MRI than the actual infected zone.
Okay, so clinical suspicion first, backed up by labs and imaging, with MRI often being key, but you still need to know the bug, which means getting samples.
Absolutely critical. Getting a reliable microbiological diagnosis is probably the single most important step towards successful treatment. You need good samples.
And we already established that swabbing a wound surface is no good.
Right. The guide is emphatic about this. Superficial swabs from wounds or sinuses are unreliable. They just grow skin bacteria and don't reflect what's causing the deep infection. Relying on them is a major pitfall.
And giving antibiotics first messes things up too.
Yes, it often leads to false negative cultures. So if the patient is stable enough, the strong preference is to get those samples before starting antibiotics.
What kind of samples should be taken?
Deep tissue samples are generally better than just fluid, especially if you suspect unusual organisms like mycobacteria or fungi. For chronic infections, and especially anything involving an implant, you need multiple samples.
How many?
The recommendation is at least 5 separate tissue samples taken directly from the suspected site of infection. And importantly, use a separate sterile instrument for each sample to avoid cross-contamination. Then get them to the lab quickly with good clinical information.
How long should the lab keep the cultures going?
For musculoskeletal infections, they recommend holding the cultures for at least 10 days. Some bugs, like Cutibacterium acnes, are slow growers and might be missed with shorter incubation times.
How do you interpret the results from multiple samples?
Generally, a definite positive diagnosis requires finding the same type of organism, phenotypically identical, growing from at least 2 of those 5 samples. That makes it much less likely to be just contamination. A single positive sample might be suggestive, but it's less certain.
Can you culture the implant itself if it's removed?
Yes. There's a technique called sonication. You basically blast the removed implant with ultrasonic waves in a fluid bath. This helps break up any biofilm on the surface and release the bacteria so they can be cultured.
Lastly, what about histology? Looking at the tissue itself.
Histopathology is crucial, especially if cultures are negative. The pathologist looks for signs of inflammation, specifically a heavy infiltration of neutrophils, which are the white blood cells that fight acute bacterial infection. Finding those neutrophils confirms infection. Histology can also sometimes directly identify the organism on special stains or diagnose specific conditions like TB by seeing granulomas.
Is there a specific threshold for neutrophils?
Yes, particularly for implant-related infections, PJI, and fracture-related infections, FRI. Finding more than 5 neutrophils per high-power microscopic field in the tissue sample is generally considered diagnostic of infection. It's a really valuable confirmation, especially in culture-negative situations.
Right, so a really thorough diagnostic pathway. Clinical picture, labs, imaging, especially MRI, but ultimately hinging on getting multiple deep tissue samples for both microbiology and histology before antibiotics, if possible. The summary box really pulls these threads together.
It does. Limitations of ESRCRP, normal early X-rays, value of ultrasound, MRI preference, uselessness of swabs, issues with prior antibiotics, need for multiple biopsies, histology confirmation. It covers the key diagnostic pillars.
Okay, diagnosis made. How do you manage these complex infections? You mentioned a team approach earlier.
Absolutely essential. It's not just one person's job. Successful management requires a multidisciplinary team effort. You need the surgeons, orthopedic, maybe plastics, infectious disease doctors, or microbiologists to guide antibiotics, therapists for rehab, pharmacists, sometimes psychologists. It takes a village.
A whole package of care, as the source puts it.
Exactly. Preoperatively, it's about thorough assessment, staging the infection, discussing all options and risks with the patient, checking their general health, and crucially, optimizing them, getting comorbidities like diabetes under control.
Then the surgery itself.
The surgery needs adequate exposure to get those deep samples first. Then the core principle. Excise all the affected tissue, dead bone, infected soft tissue, involved implants. Give 5E antibiotics, but only after the samples are taken. Stabilize the remaining bone if necessary. Manage the dead space left behind, maybe with antibiotic carriers, and ensure good soft tissue coverage, which might mean involving plastic surgeons.
Sounds like potentially very extensive surgery.
It can be. The goal is to surgically remove the source of the infection. Then post-operatively, it's about rehabilitation to regain function and continuing the right antibiotics based on the culture results with careful monitoring.
Does this all need to happen immediately?
Not always. If the patient isn't critically ill, there's often time for thorough investigation, getting the patient's health optimized, and careful surgical planning. But for the really complex cases, major bone loss, big soft tissue defects, multiple previous surgeries, Early referral to a specialist center that deals with these routinely is definitely recommended.
You keep mentioning optimizing the patient, diabetes, smoking, circulation. How big a difference does that make?
It's considered critical. Addressing these host factors significantly improves the chances of clearing the infection and getting things to heal properly. It's a vital part of the preoperative preparation.
And the psychological support.
Very important. These are tough conditions to live with and treat. The long duration, the potential for failure, the impact on life. Many patients really benefit from mental health support during the process.
Let's focus on the antibiotics. When do they get started, and what are the first choices?
Timing is everything and depends on the patient's state. If someone is really sick, septic shock, rapidly worsening infection, you have to start empirical antibiotics immediately.
Empirical meaning a best guess before cultures.
Exactly. Broad coverage based on likely pathogens. But even in that emergency, you absolutely must try to get some kind of sample, first blood cultures, aspirate obvious pus, maybe quick biopsy, right before that first dose of antibiotics goes in.
Get something, then treat if they're crashing.
Right. But for most patients, especially with chronic osteo or suspected implant infections, they're stable. In these cases, it's much better, safer, and leads to better outcomes if you delay antibiotics until you get those definitive surgical samples. That way you know exactly what you're treating.
What if they're already on antibiotics when you see them and you're planning surgery?
If it's safe for the patient, the recommendation is to stop the antibiotics for at least 2 weeks before the planned surgery or biopsy. This washout increases the chance of growing the bug from the samples.
What are typical empirical choices when you do need to start before results?
It varies by location, but the source suggests common choices for community-acquired infections might be coamoxiclav or ceftriaxone, targeting likely gram-positives.
And if you suspect resistant bugs like MRSA or Pseudomonas,
Then you broaden the coverage. Add vancomycin if MRSA is a concern, for e.g. previous history, hospital exposure. Add something like meropenem if resistant gram-negatives like Pseudomonas are likely, for e.g. severe diabetic foot infection, known colonization.
how long do the antibiotics go for? I thought it used to be weeks and weeks of IV.
That was the old standard 4 to 6 weeks 5E is common. But a really important study called the OVIVA trial changed things. It showed that for many bone and joint infections, switching to oral antibiotics is just as effective as staying on IV, provided the bug is sensitive to the oral drug and the patient can take and absorb it properly.
That's a huge deal for patients. Much easier to take pills at home.
Massive improvement in practice. Allows many to go home sooner or avoid prolonged IV lines altogether. The summary box reinforces these antibiotic principles: the urgency versus delay, the washout, empirical choices, covering resistance, and the impact of OVIVAC.
Okay, let's pivot to a specific condition. Native joint septic arthritis, infection in a natural joint. Sounds like an emergency.
It is a true orthopedic emergency because that cartilage can get destroyed so quickly. Incidence is maybe 4 to 10 per 100,000 per year in Western Europe, higher in some populations.
Who's most at risk?
Extremes of aged babies and the elderly. People with existing joint problems like rheumatoid arthritis, anyone immunocompromised, diabetes, HIV, certain meds, 4V drug users, recent joint injection or surgery. And remember, bacteria spreading through the blood is a major route.
How does the infection get into the joint?
3 main ways: hematogenous spread from the blood, direct inoculation, injury, surgery, or local extension from adjacent osteomyelitis.
What are the classic symptoms?
Usually acute or subacute onset. A single joint becomes hot, swollen, and intensely painful. Patients often hold it rigidly still in a position of comfort. Any attempt to move it, even passively, causes severe pain. That pain on movement is a key sign.
Which joints are most common?
Knee is most common overall in adults and children. Hip is common in infants.
Is fever always present?
No, that's important. Fever and feeling systemically unwell are common, but about a third of patients don't have a fever. You can't rely on it.
So how do you confirm the diagnosis if the signs can vary?
Joint fluid analysis is critical. You need to aspirate fluid from the joint with a needle.
What do you do with the fluid?
Send it for cell count, gram stain, and culture. The gram stain is quick, but only positive about a third of the time. Culture is definitive if positive, 80–90% yield, but takes days. The cell count is usually very high, 50,000 to 150,000 white cells, mostly neutrophils. But other conditions like gout can also cause high counts, so it's not foolproof on its own.
So you can't wait for the culture to come back before treating.
Absolutely not. Delaying treatment is dangerous for the joint. The decision to go for surgical washout and start antibiotics is primarily clinical, based on high suspicion and maybe the initial fluid analysis if available quickly. You treat it as septic arthritis until proven otherwise.
Makes sense. The summary box probably highlights those key presentation points.
Yeah, variable fever toxicity, usually one joint, often a pre-existing disease, position of comfort, severe pain on movement.
Okay, emergency confirmed. How is it managed?
Antibiotics alone are almost never enough. Prompt surgical drainage and debridement is the priority to save the cartilage.
How is that done? Arthroscopy.
Arthroscopic washout, keyhole surgery, is common, but it can be hard to clean out every nook and cranny, especially if there are pockets of pus. If the patient isn't improving quickly, you need a low threshold to do an open arthrotomy. Make a bigger incision to really clean the joint thoroughly.
What do you wash it out with?
Lots of sterile saline or Ringer solution. Crucially, no antiseptics inside the joint. They can damage the cartilage.
Is removing the joint lining ever needed?
Yes, a synovectomy might be done if the lining is really thick and inflamed, or if there's early bone erosion under the cartilage. More aggressive infection might need more aggressive debridement.
What if the washout isn't adequate?
Big risk of the infection becoming chronic, leading to joint destruction. Then you're looking at much bigger problems, maybe needing joint fusion, excision, or complex stage replacement later on. The images of destroyed joints are pretty sobering.
And antibiotics after surgery.
Yes, typically 3 to 6 weeks, starting 4V. The exact duration isn't perfectly defined, but longer courses might be needed for slow responders, Staph aureus infections, or if repeat washouts were required. Antibiotics are tailored to culture results once available.
So urgent surgical washout is paramount, followed by antibiotics. The summary box for septic arthritis covers this.
It does. Risk factors, common bug, S. aureus, need for aspiration first if possible, prompt surgical washout, then antibiotics.
Let's move to prosthetic joint infection, PJI. Infection around a joint replacement, a major headache.
Huge challenge. Incidence around 1% per joint per year. Lots of prevention strategies are used, clean air theaters, antibiotic prophylaxis, antibiotic cement, care bundles, but it still happens.
What makes someone more likely to get a PJI?
Patient factors like obesity, diabetes, skin conditions, inflammatory arthritis, cancer. Surgical factors like complex or revision surgery, long operating times, wound healing problems, hematomas.
How does PJI typically present? Is it always right after surgery?
No, the timing varies and gives clues. Early infections, 3 months post-op, are usually caught at surgery, often caused by virulent bugs like Staph aureus. They present acutely wound discharge, cellulitis, pain, inflammation.
What about later ones?
Delayed infections, 3–24 months, are often caused by lower virulence bugs like coag-negative staph or Cutibacteria. Maybe introduced at surgery but took time to declare themselves. Symptoms might be more subtle initially.
And really late infections, years later.
Late infections, 2 years, often present more indolently. Maybe just joint discomfort, mechanical symptoms like clicking, startup pain. Sometimes a sinus tract appears. These are usually hematogenous seeded from a bloodstream infection originating elsewhere. G.g. dental work, UTI, skin infection.
So timing helps narrow down the cause. How is PJI diagnosed definitively?
High index of suspicion is key if there's a leaking wound, new pain, loosening on x-ray, fever, pus, or persistently high CRP like DIM.
Are there formal criteria?
Yes, the European Bone and Joint Infection Society, EBJIS criteria, are widely used. PJI is confirmed if you have a sinus tract communicating with the joint, or very high synovial fluid white count, 3,000, or positive cultures from fluid tissue, or positive histology, 5 neutrophils per high power field.
And there are likely criteria too.
Right. The EBJIS system uses combinations of clinical signs, labs, imaging, fluid analysis, microbiology, and histology to categorize cases as likely infected, even if they don't meet the strict confirmed criteria. It's a structured approach.
How useful is imaging for PJI?
Plain x-rays might show loosening, but that can happen without infection too, aseptic loosening. Ultrasound can find collections. Nuclear scans, even PT-CT, struggle to reliably differentiate septic from aseptic loosening. So imaging helps assess the implant, but isn't usually diagnostic of infection on its own.
So diagnosis relies on that combination. Clinical suspicion, labs, fluid, deep samples, interpreted using criteria like EBJIS. How is PJI managed?
Again, multidisciplinary team is crucial. Ortho, plastics, infectious diseases, therapy, plus addressing comorbidities and psychological aspects.
What are the main surgical choices? Keep the implant or take it out?
That's the core decision. Salvage versus removal reimplantation. There's debate. Some base it on timing, salvage early, revise late. Others think any well-fixed implant might be salvageable with the right approach. But everyone agrees a loose infected implant must come out.
Makes sense. A wobbly infected implant isn't going to clear.
Exactly. And regardless of implant retention or removal, good soft tissue coverage is non-negotiable. Often needs plastic surgery involvement, especially around the knee or ankle.
What are the main strategies then?
One is DARE, debridement, antibiotics, and implant retention. This is only for well-fixed implants. It's not just a washout, it's a radical debridement, removing all infected soft tissue, dead bone, and exchanging modular parts like the plastic liner. It cannot be done arthroscopically, requires good soft tissue for closure.
And antibiotics after DARE.
Long course.
Yeah.
Typically 6 weeks SumV, then 6 months or more of oral antibiotics. Success rates around 80%, maybe lower for Staph aureus or resistant bugs.
Okay, DARE if fixed. If it's loose or DARE fails.
Then the standard is usually 2-stage revision. Stage 1, remove the infected implant, all cement, debris, thorough clean out, often put in a temporary antibiotic spacer, then a course of antibiotics, usually 6 weeks 4V or oral. Stage 2, after antibiotics, implant a brand new prosthesis.
Are the stages getting closer together now?
Yes, many centers are shortening the interval between stages compared to historically.
Can you do it all in one go? Single stage?
Yes, single-stage revision is an option. Remove infected implant, clean out, put new one in, all in the same surgery. Needs good soft tissues. Might be considered for less florid infections or frail patients, but the source notes a lack of strong trial data comparing it directly to 2-stage long-term.
What if reconstruction just isn't possible?
If the damage is too great or the patient too unwell, you might opt for joint removal without replacement, like a girdle stone for the hip, joint fusion, arthrodesis, for knee ankle wrist, which can be complex, or in the worst case, amputation.
What about just antibiotics forever without surgery?
That's suppressive therapy, reserved for patients unfit for or declining surgery. Aims to control symptoms, not cure. Limited data, anecdotally low success for cure.
Complex decisions. DARE for fixed, removal for loose, staged or single revision, or sometimes less reconstructive options, all with long antibiotics. The PJI summary captures these surgical pathways.
Yes, DARE for well-fixed, removal for loose, 1 versus 2-stage options, importance of sample excision, long-term suppression.
Let's touch on fracture-related infection, FRI. Infection around plates or screws fixing a break.
Happens in about 3–5% of fracture fixations, much higher for high-risk ones like open tibia fractures up to 25%, or ankle fractures in the elderly.
And the principles overlap with PJI.
A lot. Infected hardware acts similarly to an infected joint replacement, providing a surface for biofilm. Many management principles apply.
What are the scenarios and how do you manage them?
Scenario 1. The fracture isn't healed, but the fixation is stable and it's infected, usually early. Management is like DARE for fractures. Deep samples, debridement, dead space management, often local antibiotic carriers, good soft tissue cover, plastics often needed for tibia, then systemic antibiotics to suppress infection until the bone heals.
Scenario 2. Fracture has healed, but the implant gets infected later.
If the bone is solid, you can usually remove the infected implant, but still need careful debridement, samples, dead space management, and soft tissue cover.
Scenario 3. The nightmare, unhealed fracture, unstable, infected fixation.
This is tough. Stability is essential for healing and clearing infection. If the implant is loose and infected, it has to come out. Then you need to restabilize the fracture, often with an external fixator, like an Alizarov frame. This requires radical debridement of infected bone at the fracture site.
Which leaves a gap in the bone.
Often, yes. Managing that bone defect is a major reconstructive challenge, sometimes needing complex bone transport techniques. The guide shows examples of this multi-stage process. There's also mention of newer antibiotic-coated nails being used sometimes for restabilization.
What about the antibiotics specifically for PJI and FRI after the surgery?
After getting those deep samples, you start broad-spectrum empirical IV antibiotics, often vancomycin plus meropenem to cover bases.
Then narrow it down.
Exactly. Rationalized based on culture results. If cultures stay negative, you continue covering the most likely pathogens for that situation.
And the duration depends on the surgery.
Yes. If all hardware implant is removed and infection fully excised, maybe 6 weeks is enough. If it's a DARE strategy, implant retained, then it's much longer, typically 6 months total, IV than oral. For suppressive therapy, it's potentially lifelong. For chronic FRI, antibiotics often continue until the fracture is fully healed.
Is doing nothing ever an option?
For a very small subset of patients, perhaps frail with low-grade, well-tolerated symptoms, the risks of surgery or long-term antibiotics might outweigh the benefits. It's a carefully considered decision with the patient.
How do you monitor patients on these long antibiotic courses?
It needs careful planning with infectious disease specialists, supervision, checking compliance, managing side effects. Monitoring is mainly clinical symptoms, wound healing, Inflammatory markers like CRP are not reliable for predicting failure in these Cronus implant cases. Serial X-rays are useful mainly to watch for bone loss or implant changes that might suggest ongoing problems or risk of future fracture.
Okay, that covers implants. Let's revisit acute osteomyelitis, the rapid bone infection.
Presents much like septic arthritis initially. Short history, pain, swelling, loss of function, systemic illness. Common sites are the spine in adults, presenting as severe back pain, and long bones in children. A young child might just have fever and refuse to walk.
What does imaging show early on?
Again, early X-rays, first 2-3 days, are often normal. MRI is much better early, showing bone marrow edema and periosteal changes. Plain X-rays might show subtle changes only after 5-7 days.
Biomarkers.
WCC and CRP usually shoot up early. Helpful, but not definitive alone.
Should treatment wait for all the tests?
No. If you strongly suspect acute osteo, especially if the patient is sick, treatment shouldn't be delayed waiting for imaging or labs.
How is it managed?
Sometimes, if caught very early, 2-3 days, with no dead bone on imaging and no adjacent joint infection, antibiotics alone might work. Always get blood cultures. Consider guided aspiration biopsy for samples before starting if possible.
What empirical antibiotics?
Usually IV targeting gram-positive cephalosporins or flucloxacillin, add gentamicin for gram-negatives in babies under 1 year. Supportive care like splinting and pain relief is important too.
Duration and route.
Start 4, switch to oral when improving based on clinical response and cultures. Total course usually shorter, maybe 2-3 weeks.
When is surgery needed?
If there's no rapid improvement on antibiotics, if the limb gets worse, or if imaging shows progression, like an abscess forming, then surgery is needed to drain pus, remove any early dead bone, and prevent it becoming chronic.
Prognosis.
Good if treated promptly, around 90% cure. Failure leads to chronic osteo. In kids, there's the added risk of damage to growth plates or joints, causing long-term deformity. The summary box hits these points: presentation, limits of early X-ray, MRI value, raised markers, early antibiotics, surgery if needed.
Now for chronic osteomyelitis, the long haul.
A really serious condition can plague patients for decades. Best managed in specialist multidisciplinary centers with expertise in infection, comorbidities, and complex reconstruction.
Diagnosis in chronic cases. Blood tests usually normal.
Often normal, yes. Diagnosis relies on imaging and samples. Plain X-rays show the established picture swelling, bone reaction, destruction, sequestra. CT is excellent for bone detail, showing sequestra and involucrum clearly. MRI remains the best overall imaging test. Confirmation needs deep surgical cultures and histology. PT-CT can help plan complex surgery.
Is there a classification system for chronic osteo?
Yes, the BACH classifications mentioned. B for bone location, A for antimicrobial profile, C for soft tissue coverage needs, H for host status. It stresses you need to address all 4 aspects for good outcomes. Infected non-unions are always complex.
And optimizing the host status is key again.
Absolutely critical. Improving smoking status, vascular supply, diabetes control before surgery boosts cure rates, needs joint planning by ortho, plastics, ID.
How do you treat uncomplicated chronic osteo?
Surgical excision of all dead bone, local and systemic antibiotics, direct wound closure. May need temporary stabilization, external fixator, if a lot of bone is removed, potentially later bone grafting.
And the complex cases, big defects,
require major reconstruction. Often involves removing a whole segment of infected bone. Stabilization is always needed. The Elizarov method, distraction osteogenesis to regrow bone, is highlighted as a powerful technique, often combined with plastic surgery-free flaps, allows reconstruction and rehab together.
High-level stuff, antibiotic duration after surgery.
Shorter course if confident all infected bone is gone. But typically 6-12 weeks is advised for most chronic cases. Longer if there's doubt about clearance. Continue until fracture union in chronic FRI.
What about those local antibiotic carriers again?
Growing interest in absorbable ones placed in the defect. High local dose, low systemic effects. Some ceramic types might even help bone regenerate, reducing need for later grafting. Chronic osteo summary, specialist surgery, excision, stabilization, reconstruction, host optimization, typical 6-12 week antibiotic course.
Let's move to diabetic foot infection. Huge problem with rising diabetes rates.
Massive problem.
Yeah.
Leading cause of hospital admission for diabetics, 1-2% annual complication rate.
Why is the diabetic foot so vulnerable?
Combination of poor blood flow, macro and microvascular, nerve damage, neuropathy leading to loss of sensation and skin changes, foot deformities, impaired immunity, and poor healing. A perfect storm.
So ulcers are common entry points.
Very common, especially over pressure points like the heel or ball of the foot. Infection starts easily and spreads fast in compromised tissue. The pictures often show how devastating it can be.
Clinical signs.
Local inflammation around an ulcer, redness, swelling, warmth, pain, maybe systemic upset, non-healing wound, spreading cellulitis. Fever or signs of critical ischemia are red flags for severe urgent infection.
Are blood tests reliable?
Often not very helpful. Inflammatory markers might be normal or only slightly up, even with deep infection, possibly due to the underlying immune issues.
Imaging.
X-rays might show bone involvement, but can be normal early. MRI is most sensitive for detecting osteomyelitis in the diabetic foot.
And sampling. Still no superficial swabs.
Absolutely not reliable. Swabs from ulcers just gross surface contaminants.
So bone biopsy is needed.
It's the gold standard for deep infection, especially in complex cases. Maybe not needed for very mild suspected bone involvement.
Is there that clinical test, probe to bone?
Yes, if a sterile probe gently inserted into the ulcer base hits bone, especially combined with raised inflammatory markers and suggestive X-rays, it strongly suggests underlying osteomyelitis.
What bugs are common?
Similar to non-diabetic osteo, Staph aureus, strep, gram-negatives. But Pseudomonas is more common, so needs empirical cover in severe cases. Anaerobes might be present too, especially with dead tissue, so consider metronidazole.
Management.
Surgical debridement is needed for pus, dead tissue, or definite osteomyelitis. Important to distinguish superficial bone exposure, osteitis, due to tissue loss poor blood supply from true deep infection.
What about that superficial osteitis?
Optimizing blood sugar, improving blood flow, and offloading pressure, footwear, might be more important than antibiotics and can potentially avoid major surgery. Focus on the underlying causes.
Vascular assessment is crucial then.
Mandatory if pulses are poor. Poor blood flow means poor healing. Procedures like angioplasty or bypass are often needed before surgery to give the foot a chance to heal afterwards.
And amputation is common.
Sadly, yes, up to 20% in some series. Healing after amputation is also challenging in diabetics. Surgery needs to remove all infected tissue, sometimes sacrificing extra bone for tension-free closure. Below knee amputation might be better than foot amputation if neuropathy is severe, diabetic foot summary, ulcer risk, unreliable swabs, consider biopsy, debridement for severe disease, tailored antibiotics, critical vascular pressure management.
Finally, mycobacterial infections, TB, and related bugs.
Right, caused by mycobacteria. Tuberculous arthritis osteomyelitis, still common in many parts of the world, resurgent elsewhere due to migration, HIV. Mycobacterium tuberculosis is the main culprit.
Where does TB usually hit the skeleton?
Spine is most common, 50% of cases, often affecting the discs and vertebrae. Can also cause monoarticular arthritis, usually in large weight-bearing joints.
How is skeletal TB managed?
He's a specialist TB multidisciplinary team. Involves screening, HIV, etc., checking for TB elsewhere, monitoring liver-kidney function, drug toxicity is common, checking hearing vision for some drugs, managing drug interactions, especially rifampicin.
Rifampicin interacts with a lot.
A huge number of drugs. Very important to manage. Plus, infection control, contact tracing, patient support for adherence to long treatment.
What's the standard drug regimen for sensitive TB?
Usually 4 drugs, rifampicin, isoniazid, pyrazinamide, ethambutol, for 2 months. Then 2 drugs, rifampicin, isoniazid, for 4 months. Total of 6 months.
What about drug-resistant TB?
A growing problem. MDR-TB and XDR-TB need complex, prolonged 18-24+ months, toxic regimens using second-line drugs, often including injectables, based on susceptibility testing. Many side effects.
Does surgery have a big role?
Limited role compared to bacterial infections, mainly for spinal decompression stabilization if nerves are compressed or spine unstable, or occasionally for diagnostic biopsy. Antibiotics are the mainstay.
And the non-tuberculous mycobacteria, NTM.
Environmental organisms mainly cause disease in immunocompromised people or related to trauma processes, but can occasionally affect healthy individuals.
Treatment for NTM.
Difficult, often resistant to standard TB drugs. Surgery, debridement drainage, is very important to reduce the bacterial load. Drug regimens are complex, individualized based on susceptibility testing, extent of surgery, organism, patient factors. Needs expert oversight. No standard regimen.
So mycobacterial infections are a whole different ballgame, needing specialized diagnosis and long, complex drug therapy.
Exactly. Distinct challenges.
Wow. That was certainly a deep dive. We've covered a huge amount from ancient history to modern challenges like implants, the underlying pathology, the detailed diagnostic process, and the complex multidisciplinary management from antibiotics to major reconstructive surgery.
We really traced the journey through acute and chronic osteomyelitis, septic arthritis, PJI, FRI, diabetic foot, and mycobacterial infections. It highlights just how varied these conditions are and how treatment has to be tailored considering the bug, the bone, the soft tissues, and the patient themselves.
Hopefully, this detailed exploration has given you, our listener, that robust understanding we aimed for. Getting into these specifics is really necessary to appreciate the nuances.
It definitely shows how dynamic the field is. And thinking ahead, with aging populations, rising diabetes rates, more implants being used, how is this landscape of orthopedic infection going to keep changing?
That's a great final thought. What new innovations, surgical or medical, will we need to keep pace with these evolving challenges? It's a constant learning curve.
It certainly is. Continuous learning is key in this field.